Just a little review video in regards to endo. As some of you have gone through and done your activities, some questions have come up that I definitely want to make sure that I address to hopefully make it a little bit easier to understand or to clarify some things. So one of the questions is dealing with a difference between pulpotomy and pulpectomy. And the way I have what was helpful for me to understand these two was, first thing is to break down the word and to try to determine what it is that it's going to be talking about. So medical terminology is going to play a huge part when it comes to terminology and words that maybe you're not quite understanding, because that kind of helps to identify what it is that you're going to be doing. So again, if we're looking at the suffixes otomy and ectomy, we know that otomy is to cut into, ectomy is the surgical removal or excision of something. So we know that with ectomy, something is going to be removed. With otomy, something is just going to be cut out. So it's not going to be completely removed, but a portion of it is going to be cut out. So pulpotomy, pulpectomy, for me, what's always been helpful for me is to think of P and primary. We often utilize these terms, pulpotomy, pulpectomy, when we're dealing with children, and primary teeth or baby teeth. So even though pulpectomy means root canal therapy, because they're both doing the same thing, you're still removing the pulp, whether it's diseased due to physical irritation or trauma. We need to make sure that we're removing that to allow for material to be placed in and to provide a really good seal on the tooth, thus allowing the patient to hopefully keep the tooth for a long period of time. The purpose with pulpectomy and root canal is longevity. We know that it's always best to keep our teeth because it also helps to preserve our alveolar bone. And if we remove a tooth, that alveolar bone starts to recede, and then just over time, it gets worse and worse and worse. So the longer we can keep a tooth, the better off the patient is going to be in the long run. So pulpectomy, pulpotomy, P, primary, baby teeth. However, pulpectomy, root canal are basically meaning the same thing. So you might have a dentist or endodontist that is referring to a pulpectomy and know that they're talking about a root canal. So with that, again, pulpectomy, we're removing the coronal portion of the pulp as well as what's in the radicular portion, and we're making sure that all of that is thoroughly cleaned out, and we then replace it with gutta percha, a material, to ensure that it is sealed all the way down to what would be the apical foramen, to prevent any bacteria and any debris from getting back into the tooth that can reinfect it and cause issues, which we know that does happen sometimes. Maybe if a seal a tooth wasn't sealed correctly the first time, the endodontist may have to go back in and do a retreat, where basically they're doing the same exact thing as a root canal, except now they're having to remove, instead of the pulp tissue, they're having to remove the gutta percha that was placed in there beforehand. With a pulpotomy, what's being done is just the coronal portion of the pulp is going to be removed. And the way to think about this is, again, to look back to this diagram here. We know that there's a significant difference between primary teeth and permanent teeth. Our primary teeth are a little bit wider. The pulp chamber is going to be a lot larger in a primary tooth than it is going to be in a permanent tooth. In a permanent tooth, we have a majority of the tooth which is comprised of dentin. And so what happens a lot of times is, even though there's physical irritation like decay or even trauma that has occurred to a permanent tooth, because the pulp canal is much smaller, it often is not just going to affect the pulp chamber, but it's also going to affect the radicular pulp in each of these canals. Whereas in a primary tooth, because pulp chamber is so large, oftentimes we can get away with just removing the coronal portion of the pulp, and putting a material in there that helps to preserve the radicular pulp tissue and allow it to continue to be vital. Another thing when it comes to pulpotomy and pulpectomy is that with a pulpectomy or root canal, we're wanting to preserve the tooth for a long period of time. And the only way to ensure that that's going to happen is by thoroughly removing all of the radicular pulp as well and sealing that off with the gutta percha. With a pulpotomy, we can get by with just removing the coronal portion, assuming that just the coronal portion of the tooth has been affected. But because we're not having to preserve that tooth for a long period of time, we know that eventually the tooth, the primary tooth, is going to be lost. It's going to come out, and it's going to then be replaced by a permanent tooth that's coming into its place. There are times when a pulpectomy is going to have to be done on a primary tooth, which is why P for primary, often called baby root canal, is because the trauma is so severe that it has affected also the radicular pulp, and a root canal is going to have to be performed, or a pulpectomy is going to have to be performed, because that tooth is not ready to come out. It might be several years before the tooth is set to come out, so we want to make sure that we're preserving that space, because remember, our baby teeth are space holders for our permanent teeth, and if we remove a primary tooth too soon, it can cause a lot of issues down the road when the permanent tooth starts to erupt. So pulpotomy is going to be done primarily on a tooth that the radicular pulp isn't affected. The radicular pulp tissue is still vital, but we just want to get rid of what's diseased to preserve that. And it's something that the patient may have for maybe a year, and then they're going to lose a tooth. So it's meant to be more of a temporary type of situation for a tooth that's eventually going to be lost sooner than it would be if the tooth needed to have a pulpectomy. So I hope that helps to clarify the difference between the two. Pulpectomy, remember, it's removal of everything, which is the same thing as a root canal. So you might hear those again being interchanged. Next question was in regards to instruments, and I know instruments are always a challenge. It doesn't matter if it's a specialty or restorative or what it is, because in dentistry we work a lot with instruments, and every procedure has their own set of instruments. So you'll get really familiar with instruments once you start working with them a little bit more. They're definitely going to be a lot easier to remember what they are and what they're used for. With instruments, when it comes to files, again, it's going to be preference of the dentist or endodontist as to what he or she likes to use. Some may use a lot of different files, and some may just strictly stay with one file, maybe work between a couple of them, but that's going to be all. But when it comes to files, the best thing to do is always to look at the working end to be able to identify what type of file it is. As the files are packaged, as with anything, it's always going to have an identifier as to what it is, and also the size of the file, because remember, the dentist measures the length of the canal in millimeters. So we'll have files anywhere from 21 millimeters on up to 50 or 60 millimeters, just depending. So again, the file will correspond to the gutta percha that is going to be placed into that tooth to seal it off. So whatever file number you ended off with, then that's the corresponding gutta percha that you're going to be using. So if you ended up with a 40 file, then you're going to correspond that with a 40 for gutta percha, and that's going to represent the size and thickness of the gutta percha. So K file is going to be twisted. The working end is twisted, but it's going to have the blades where they're going to be closer together. K files are used initially to remove tissue, whether it's vital or not, and to also try to remove debris and also to start to shape. The reamer is going to be used more so once debris has been removed from the canal to start to shape the canal to make it make the opening a little bit larger to accommodate the gutta percha to fit in there. So same thing, it's a twisted type, but the blades of the reamer are going to be spread further apart. And then you have your headstrom file, which the working end is going to have a larger cutting edge to it. So this is really going to help to shape those canals and to really make them enlarged, more so than your K file or your reamer. The barbed brooch is very easy to remember because always think of like a barbed wire. The way it's shaped, that's very similar to how the barbed brooch looks like as well. When it comes to hand instruments, I did want to kind of just show a few here. We have our spoon excavator, and we have a traditional spoon excavator that we would use in a restorative setup, and then we have our spoon excavator that we would use in endo, and we can see that they look the same. The only difference is that the restorative spoon excavator is a lot smaller in size than your endo spoon excavator, and that's again to allow for the endo instrument to fit into the tooth to be able to remove any debris from the coronal portion of the tooth. So they need to get in there, so it needs to be long enough to get into the tooth as it's opened up. We have also our endo spreader and our plugger, and the way we can tell the difference between the spreader and the plugger, I don't know if you can see that here, but our spreader is going to, see if I can get a close-up, which is here on top, is going to be pointy, whereas our plugger is going to be a little bit more blunt on the edge, and it's going to kind of be flat, so we can see kind of a little bit better here, hopefully, where it's going to be kind of flat versus the spreader, which is going to be pointy. So the way these work is that when the gutta percha is placed into the canal to get ready to seal, the spreader is used to do just that. It's there to help move the gutta percha over to accommodate more gutta percha points to fit into the canal, because our goal, remember, is to get a really good seal, not only down to the apex, but also the entire width of the canal itself. So the spreader helps to move the gutta percha over, and another one is placed, moved over, another one is placed, and so on and so forth until the entire portion of the canal is going to be filled up with gutta percha. So that is the purpose of the spreader. The plugger then is then taken, just like we have a condenser in amalgam that helps to push the amalgam material down to pack it in so that there's no space between the material as it's being placed in the tooth. Same thing with the plugger. We want to make sure that that gutta percha is all the way down to the apical foramen to seal off the tip of the root. So what they're going to do is they're going to push the gutta percha down into the canals to ensure that it's going to have that proper seal at the bottom of it, like it needs to have. Oftentimes what they'll do is they'll heat up the instrument because once the gutta percha has cooled down, it's going to become a little bit more stiff and rigid. When it's heated, it becomes flexible and more pliable. So again, they want to make sure that it's going to be pushed down into that canal to make sure that it's all the way down to the tip of that root. Next instrument that we have is our Glick number 1, which again it's a double-ended instrument. One end has a paddle to it. The other end looks very similar to the endo plugger. And the Glick is often used towards the end of the procedure. Again, same thing, they're able to make sure that the gutta percha is condensed in there. As the gutta percha is sticking up over into the pulp chamber, they need to make sure that they cut that down and make it even with the opening of the canal. So oftentimes what they'll do is they'll either heat this end up or this end up, and they'll basically cut off that gutta percha, that excess gutta percha. And they might even make sure and pack it down even further. They may use the paddle end here to place a temporary material until the dentist can get back into their general dentist to have the permanent restoration placed. Glick number 1, not to be confused with the Woodson. As you can see, the Woodson looks a little bit similar. It's also a double-ended instrument. You're going to find Woodsons more often in your restorative setups, but you might also find it in endo setup as well. But it has a paddle end that would be used to place material and more of a condenser end that looks more similar to your restorative condenser to push the material down. So again, you might have one or both of these in your setups, but make sure you have an understanding of the Glick number 1 and why it's used in endo. Again, has more of an endo plugger to it and a paddle to cut off material, excess material, and also to place temporary material. Another question that came up that I do want to make sure I address is the control tooth. We use a control tooth to allow for the patient to have a better understanding of what would be considered normal as we're doing the different types of testing and what would be considered not normal. So we often want to use the same tooth that's on the opposite end of the tooth that we're working on. But the question came up that what happens if the patient is missing the tooth on the opposite end? Then what happens at that point? Well, again, it's going to depend on the dentist, but the dentist is more than likely going to use a different tooth on the opposite end. Obviously, the patient wasn't experiencing any kind of symptoms on the other side of their mouth. So as they're doing the percussion, the palpation, any thermal testing, the patient will be able to understand what they're asking for. So when the ice is placed on the tooth, they're able to identify that it's cold and that when the ice is removed, it goes away. Versus on the tooth that is symptomatic, when the ice is placed on there, either the patient is not feeling anything at all, or they might feel relief from the pain when the ice is on the tooth, or they might feel that it's cold, and as the ice is taken away, it might linger as far as the pain, and then it goes away. So you might also find that the dentist might even use the tooth in front of or even behind the tooth that is experiencing symptoms. So again, it's going to depend on the dentist and what he or she wants to do, but the control tooth is just a way to have the patient understand what would be considered normal versus what's not. So they understand that when, the dentist is tapping on the tooth, this is what it should feel like. You feel that I'm tapping. It shouldn't have any pain, any discomfort, other than you feel me tapping on it. Versus this one here, you might be feeling the pressure. You might feel pain. You might experience a shooting pain, or you might not experience anything at all. So again, just as a way to get an understanding from the patient as far as what they know to be normal and what is not normal. So I hope this video helps to clarify some things, especially when it comes to endo, and I appreciate the questions. I think it's very important to have a clear understanding of what it is that you're learning about, and I think it's really important that you ask questions and don't ever be afraid to do so. That's the only way you're going to learn. If for some reason there's still not some clarification from this video, please reach out to me again, and I'm happy to maybe talk with you a little bit more one-on-one, just so you can have a good idea or get some better clarification or better understanding.